Now the last topic of the squint, that is gaze palsy, restrictive squint and comitant squint with miscellaneous. So basically there are two types of gaze. These are horizontal and vertical gaze. Okay. So what is the basic definition? So these are controlling the two muscles. Okay. So supranuclear gaze controls the center, which is in the cortex, and gives input to the nucleus of the cranial nerve 6, 4 and 3. Okay, which leads to a binocular vision. Very important, students. So it controls two muscles. Okay, and the supranuclear gaze control center, which is in the cortex, it gives input to the nucleus of the cranial nerve 3, 4 and 6, which leads to binocular vision. Okay, now ipsilateral lateral rectus, it is controlled by the sixth cranial nerve. It is controlled by the sixth cranial nerve. Contralateral medial rectus, it is controlled by the third cranial nerve. So basically we have studied these all in the further subtopics in the previous videos. Okay, now the gaze movement, the most important topic. Gaze movements are of two type. These are saccade and pursuit. Okay, so saccade gaze movement and pursuit gaze movement. What is a saccade gaze movement? So a rapid fixating movement. Remember, it is a rapid fixating movement and it is a slow maintaining movement. Okay, so a rapid fixating movement which is initiated in the frontal cortex. Okay, this is saccade, and the pursuit is the slow maintenance movement which is initiated in the occipital cortex. Okay, two different things. Now saccade is further of two types. Okay, these are horizontal gaze and vertical gaze. The horizontal gaze is controlled by the contralateral cortex, and the vertical gaze is controlled by the bilateral cortex. Okay, now we'll study in brief detail about these all. So the first comes is your horizontal gaze pathway, and it can be understood by taking an example of a single gaze in a left gaze. Okay, so we are taking an example of left gaze. So what basically structures you can see in this? So these structures, what are these? These are the involvement of contralateral FEF. Okay, the next is ipsilateral PPRF. PPRF is what? Parapontine reticular formation. Okay, and contralateral MLF. What are contralateral MLF means? With the medial longitudinal fasciculus. Okay, so what is the note given over here? That MLF is not, has no role in the lateral reticulus and only controls the medial reticulus. Okay, so it has no role in the lateral reticulus, it only controls the medial reticulus. The horizontal gaze lesion, so there are basically lesions in the left horizontal gaze pathway. Okay, and these are at the three sites. What are these three sites? These are left FEF, left PPRF and right MLF lesions. Okay, and respectively they'll cause different types of gaze palsies. Okay, now so this is a primary condition in which there is a normal vision and both the eyes are looking forward. Okay, as you can see. Now another condition where the right gaze, as both the eyes have moved together and the right side has no effect. Okay, so the right side has no effect when it sees to the right. Now in the next vision, the left gaze, left gaze, but none of the eyeball is moving. Okay, so in the left side there is problem because no movement is over there. Okay, So therefore the left gaze is palsied. Okay, now this left gaze palsy can occur due to both right FEF lesion and the left PPRF lesion. Okay, so it can occur due to these two things. Now in the second case, again a normal vision, then the right gaze, both the eyeballs are moving towards the right and there is no defect over here. Then comes at the left gaze. The left gaze, in the left gaze you can clearly see over here the right eye is not able to adduct. Okay, it should be going over here, but it is looking at the front only. Okay, this eye is normal, but this eye is having a palsy. Okay, so what is it? So the left gaze, the left eye is abducted. Okay, so it's normal. This is the left one, this is the right one. Now the right eye has not been able to adduct, so here is a abnormality over here in the right eye. Okay, so in which muscle there would be a palsy or a problem? There would be right medial rectal muscle palsy or problem. Okay, so since only one of the muscle is getting affected over here, okay, and that is the medial rectus, so the lesion is known as right MLF. Okay, very simple. Now in left gaze defect, note one thing, that the left eye abducted in the condition is accompanied by nystagmus movement. Okay, so in left eye abduction the condition accompanies this nystagmus movement. Now comes the third case, another normal image. Then we told patient to primary gaze when both the eyes are looking at the front. Then we told the patient to look at the right side. Okay, so this will be the right eye and this will be the left eye. So the left eye is not moving in this condition and the right eye is abducted. Okay, so there is a problem in the left eye. Let's see. So here you can see the left gaze, the left eye is able to not move. Okay, the left eye is not able to move, but the right eye is able to move. So here is the abnormality in the left eye abduction. Okay, and this is absent, so it is left eye MLF lesion. It is nothing but left eye MLF lesion. Okay, now this was only a movement towards the right side. What would happen when the person would be seeing at the left side? Okay, so when the person would be seeing at the left side, both the eyes will not abduct. Okay, so the left gaze, none of the eye is able to move. Okay, so this is the condition and this is left PPRF lesion, very important. Now the next comes is the vertical gaze pathway. Okay, now the vertical gaze is further divided into primary center and the secondary centers. It has two centers. Now the RIMLF is the primary center. Okay, now the full form of RIMLS is rostral interstitial medial longitudinal, and the secondary center it is INC. Okay, interstitial nucleus of Cajal fasciculus. Okay, so these are the two centers. Now the next common is the vertical gaze palsy. Okay, now vertical gaze, as we saw, two parts. Now what is vertical gaze palsy? So the most common is in the distal basal artery ischemia. So vertical gaze palsy is most common cause is distal basal artery ischemia. Another cause is progressive supranuclear palsy, and this can be seen in old ages. And initially how it is seen, so the name itself tell us that it is progressive, okay, and if it is progressive, then it will occur after something. So first is the down gaze palsy, then comes the up gaze palsy, then is the global palsy, and finally convergent palsy occurs. So this is the order in which it progresses. Now the third cause over here is Parinot's dorsal midbrain syndrome. Okay, and the cause of this syndrome is pinealoma. Okay, now the site of lesion is in the posterior commissure, which is connected both with RIMLF. Okay, which is connected both with RIMLF. Now, so basically both the RIMLF centers are connected, and the palsy of this leads to this. Okay, now what are the clinical features associated over here? So the clinical features are supranuclear up gaze palsy, okay, up gaze palsy, and the light near dissociation. Okay, so the light is near dissociation, light reflection is absent, and the near reflection is present. Okay, now you can clinically see a Collier's sign at the upper eyelid retraction. Okay, so Collier's signs is nothing but the upper eyelid retraction. Okay, now restrictive squint, it is due to external restriction. It is due to external restriction. It is not due to any palsy. Okay, so it is due to external resistance. Okay, so the name itself tell us that there would be some resistance which will lead to resistive squint. Okay, it could be diagnosed by FDI. Okay, force detection test. So that was all about squint. Now we'll study in our next lecture about the lens anatomy, metabolism and dissociation.